Welcome to Patient-Specific Conversations, brought to you by Axial 3D, where we explore patient-specific surgery and medical technology, people, and all the innovation behind it. I'm your host, Rory Hanratty, and in today's episode, we are talking with Chris Rumana. He is a board member of several different companies and organizations in and around healthcare, chairman of Axial 3D's board, also previously a neurosurgeon, and you've held several leadership positions within hospitals. So I think it's fair to say you've a lot of experience in the world of healthcare. So everyone sit back, relax, and get inspired as the future of patient-specific surgery is just a conversation away. So, Chris, welcome.
Thank you very much, Rory. Glad to be here.
And I'm very happy that you were able to kind of join us after a bit of a trip around Europe, where I think you took in a lot of our nice weather over here in terms of cold and rain, and probably a few other bits and pieces besides.
You know what? The people were great. The scenery was great. It was a wonderful time. I couldn't have enjoyed it more.
Awesome. Super cool. So let's dive into it. What we'd like to do today, Chris, is just to kind of get your take on innovation in and around healthcare, how that's going to change things like pre-surgical planning and so on, and some of the challenges that are associated with kind of bringing anything new really into the healthcare system. So let's start off with that kind of angle around the challenges that you've seen in your experience in your career around hospitals adopting new technology, especially when things are starting to change so fast, because I think the kind of pace of innovation has accelerated quite a lot in the last 5-10 years. So from your point of view, what are the kind of key challenges that you see out there?
Well, the real situation is this. There is no doubt in medicine that if you give the right patient the right care at the right time, you will have better outcomes. The patient's outcome, their time in the hospital will be less, their overall healthcare cost will be less, and their outcomes will be better. There's just no doubt about that. The problem that comes up is, how do you prove that some sort of a new technology will actually do that? Is this simply a cost, or is truly a benefit? And where hospital administrators, both in Europe and in the US, have an issue is that they're very leery, that the margins are small. And so they're very, very leery about adding on new costs without being relatively sure that it is going to be a benefit. Intuitively, we know that if you plan out a procedure better, the result will go better. I mean, let's be honest. If you're trying to give a speech and you walk up and someone says, Rory, walk out in front of this crowd and give a 15-minute speech on some sort of technological endeavor, you probably can do an okay job. But if someone says, Rory, next week I want you to go out and give a 15-minute speech on the same technological endeavor, and you plan it out better, well, you'll do a better job, right? Not that you wouldn't do a bad job if you just wing it, but you will do a better job if you can plan it out. So intuitively, we know this to be true. But in a hospital setting, very commonly, they like to have proof. And so what proof really involves is research and study to show the value of some sort of a new technique, new procedure. And if you can do that, then very commonly, you will have a good way to get inside the hospital system. But if you can't do that, it's a problem because, there's a very large fear of bringing in a new cost without a clear benefit.
And let's talk, that's interesting. Let's talk a little bit about cost as well, because I suppose the cost isn't just the monetary cost that's associated with the procedure. There are other things that a surgeon needs to think about in terms of cost, like time, I guess, is going to be a factor there as well. Maybe change to current care pathway might need to be revisited. So it's not just the per procedure cost from a money point of view. Like there are other things that would be considered there too, right?
Certainly. When you talk to a physician about changing their pattern of care, doctors are commonly willing to change their pattern of care if you can answer one question. I call it answering the why. So if someone comes up and says, Dr. Romana, why don't you try this new technique? First thing in my head is I'm going to say, well, why should I do that? I've been doing it my way for the past 15 years, and it seems to be going fine. Why should I change and do what you have to do? Why should I change what I'm doing? Why should I change what I'm doing? And so if you can answer that one question, then you have a very good chance to convince someone to do something. But you've got to change the doctor's mentality from what they were doing to a new pathway, a new clinical pathway. And they're probably comfortable with what they've been doing in the past. So, that's one hurdle to get over. The second hurdle is all of the people around you. All of the people around you have an experience level, and they're comfortable also doing things how they've been doing them. So you've got to convince all of them to change their pathway as well. So there is a there is a status quo hurdle to get over. Next, there are some procedural hurdles. Most commonly, there is some sort of a policy and procedure as to how you go about doing almost anything in a hospital, because you want to do something in whatever the best way is to do a procedure or to do some sort of a clinical job. You want to have that be the way it's always done. Well, if you try to change that, then you need to have a good reason why you're going to change that. So there are a variety of issues that come up around policies and procedures, around comfort level, around status quo levels, and in convincing the hospital, the doctor, and their surrounding team that there is a real reason to make this change. So there's some effort that happens just changing the status quo.
Okay, and have you kind of any examples that you can lean towards where you've kind of seen that successfully happen, or how do, I guess the reason for this question is to help people who are interested in or have identified maybe some new innovation around pre-surgical planning or patient-specific surgery that they would like to engage with clinicians around, but just don't quite know how to have that conversation and how to convince all those people that this is worth trying.
Well, I think that goes back to answering the why. You need to find some sort of evidence that your new plan is better than the plan that was being done before. If someone says, why don't you try this new device, this new implant, this new whatever, why should I change? Well, I need a reason to change. And that reason is generally some sort of scientific evidence that you get better clinical outcomes, you get better economic outcomes, your length of stay is less, your infection rate is less. It can be one of multiple things, but you need to show some sort of a benefit to changing to that new plan. And if you can show that, then you have a very good argument as to why you should change the clinical care pathway that you currently have to the one which you think would be better.
I think that's an important point for if people are listening to this and are kind of coming at it from I guess more of a technology oriented perspective, is that, like, for example, Chris, if I was to turn up tomorrow and tell you that I have this great new way of maybe reading a RAD report and it uses generative AI. That doesn't answer the why for you at all. Like, I don't think I'd really get much further than a nice to meet you, Rory. Catch you next time. Whereas if I turn up and say this will save, the time when you're reading these procedures, or it increases the accuracy of what you're doing, then you're more likely to kind of go, okay, talk to me some more about how this might work.
Certainly. And actually, commonly you have two separate thresholds to meet and two separate people to convince to try something new in a hospital setting. And they have sometimes two separate things that will really convince them. On the doctor's side, it's general clinical efficacy, right? You should try this because your patients will have a 20% better outcome, a decreased infection rate, your surgical time will decrease, something along those lines. And it's usually going to be clinical for the physician involved. Now, for the hospital, it's oftentimes very different. For the hospital, it's very commonly a cost analysis. Because if you say to them, hey, I can do 1% better on my surgeries, it's going to cost you $100 million, they're not going to be very excited. But if you can show the hospital how they will have cost savings by shorter inpatient stays, decreased readmission for infection, better patient outcomes with less pain following some sort of an implant surgery, whatever, some sort of a way in which they financially are benefited, then that's oftentimes going to benefit the hospital. And financially benefited isn't necessarily a direct dollar savings. It can be oftentimes an indirect savings. How much money do you save by having the patient go home 2 days earlier? How much money do you save by them being in the ICU for 1 day less? How much money do you save by a decreased readmission rate? So there can be a lot of indirect cost savings. You can spend some money directly to save a lot more money indirectly, but very commonly in a hospital, you're going to be focusing on financial issues and also commonly, optimally, some quality of care issues. Whereas the physician probably is less worried about the financial issues because he's probably not paying the bill anyway. And he's probably more worried about, quality of care issues and such.
Right. And there's those indirect costs, I guess, they have significant knock-on for lots of other things in the hospital. If you have a patient that goes home a day earlier, that means that you can bring in another patient a day earlier. And it all kind of adds up to net benefit for the hospital system overall, if you can kind of make that case.
Absolutely. In fact, what we're seeing is patients do better at home. So there's a big push to get patients out of the hospital, for example, after total joint replacement. It used to be that you'd be in the hospital for multiple days and then go to an inpatient rehab setting. As time has gone by, you'd be in the hospital for multiple days and then go home. And then as further time has gone by, you're commonly doing these procedures either as an outpatient or maybe an overnight stay and going directly home. And what you find out of that is, although the patient might intuitively think that if I'm in a hospital setting and I've got people around me and nurses around me and such, I will do better and I will have less infection. It's not really turning out that way. In fact, you have a lower infection rate if you get out of the hospital, because inside the hospital is a whole bunch of infected, dirty people. I mean, quite honestly.
I know, yeah. It's interesting that you pick up on that one. There was my dad recently had a stroke, and their goal was to get him moved out of intensive care safely, but as quickly as they could, into kind of a rehab setting, and then try to get him home, because the evidence was pointing towards that, is that if he's kind of trying to get plugged back into his life quicker, he's going to have a better outcome, and it's allowing him to kind of adjust to the new reality he has to deal with, and that would take longer to do, I think, if he was in a hospital setting for longer. It's a very, very different experience for the patient, I guess, being in somewhere which is, well, it's there to look after people who are chronically or acutely ill. So yeah, it's a really interesting point. On that one then, Chris, over the years, have you seen shift in the way patients engage with healthcare in terms of the level of information that they'd like to have, the understanding that they'd like to have around maybe the procedures that they're going to undergo, and that kind of thing? What have you seen change over the years in that side of things?
Well, if you just think of the internet, I mean, all sorts of information is available at the touch of a button. And that's both good and bad, because patients come in sometimes with some preconceived notions. They may be absolutely correct. They may have done a lot of research on their own condition, and they may come in really quite knowledgeable about their condition and have a very high level educated discussion with their physician about their condition. They may be able to um, almost assist in their care because they understand the situation and such. Although on the other side, as you well know, there's a lot of not very good information on the internet. We can say, that's sort of putting it politely. There's a lot of crap out there. And so sometimes patients come in with a complete misconception about what's going on. They may do some sort of a search, be led down a wrong pathway. And when, as a doctor, if you start telling them something very much different than what they believe to be true, they automatically will, they may not trust you as much, because you're telling them something that doesn't confirm their pre-existing belief system. And so it's both good and bad. We try to steer people to good sources of information. And if you do that, then very commonly they can be an active participant in their own healthcare. There is a small downside, though, which is if they have gotten a variety of some bad information, then they may have some misconceptions about their condition, their treatment options, their expected outcomes. And sometimes those patients are not as happy when you try to talk to them because you are not confirming what they already believe to be true. And so in their mind, there's a reasonable chance that you're wrong.
Right. Oh, yeah, I understand. So there's kind of positives and negatives to any introduction of any new technology, whether it's the internet and people's availability to look for information, or I guess, different types of interventions that they might have. People, yeah, like you say, people may turn up with preconceived ideas around that. I'm gonna leans a little bit towards something else that I suppose may accelerate that factor, is things like AI, and some things like ChatGPT, where somebody can ask a question and it comes up with information that on the face of it looks like quite credible, but actually may compound that kind of lack of trust, I suppose, between clinicians and what they could find on the internet.
Certainly. I mean, there are plenty of examples of people using ChatGPT or some sort of other similar modality and getting something that's completely wrong. And it's difficult to know for sure when something is wrong. I mean, if you truly don't know much about a topic, you ask ChatGPT about something and it gives you some completely wrong answer, you may assume that to be true, because why wouldn't you? And so there is some potential harm. Harm may not be the right word. There is certainly a downside to trusting everything that you see or read.
So let's talk a little bit specifically about kind of the idea of patient-specific planning, and this is something that I kind of, or patient-specific pre-surgical planning, and this is something that I kind of like to kind of remind people of, is that it sort of sounds a little counterintuitive to say the phrase patient-specific planning, because all of the plans are for a patient. But what we're really talking about here is the difference between what, maybe people learned while they're in med school, or they might have, researched a little bit as a patient beforehand and seen maybe, let's say, a diagram of your spine. And they assume that my spine is exactly the same as the one in the book. And in reality, that's not the case. People have different alignments, the vertebrae are different sizes, and so on and so forth. So what has changed over the last number of years around that introduction of what is more patient specific based on your imaging or the kind of diagnosis that you've had, and how that's changing how procedures are performed?
Well, just like we talked about, if you walked out in front of a group with a 5-second notice and were told to go give a speech, you would do the very best job you could as you made it up on the fly. But if you had a week to prepare for this and you knew exactly what the topic was and you were completely ready for it, you would do a better job. Now, you hear a lot of times surgeons say, well, I'm going to have to get in there to see what we really have, and then I'll fix what we have, right? And you hear that a lot. The reason someone would say that is because their pre-surgical knowledge is not perfect, right? They have some gaps in they think they know what they're seeing, but they're not entirely sure. So over the years, if you think of the imaging studies, they've gotten progressively better. At one point, we used regular x-rays for everything. And then a CT scan came along, and that will certainly give you much better visualization. And then the MRI scan came along, again, much better visualization. And there are different kinds of modalities you can use in CT, in MRI, different imaging sequences, and on to tell you more and more about a condition. And everything you can do beforehand, get an MRI scan, be pretty sure you know what the anatomy is, get a CT scan, be pretty sure you know what the anatomy is. Everything you can do to be more sure of what you're going to find when you begin a surgery, it is better. There is no doubt about it. So the more you can do before a procedure is ongoing, to understand what you're going to do, to plan in your head how this operation is going to go, the better it's likely to go. The less you're likely to get in there and see what you have and figure it out. Now, you can take that to a much further degree as well. Let's suppose you know exactly how bad someone's knee is. I mean, it's really bad. You need a knee replacement. Okay. Even so, the orthopedic surgeon goes into the operating room saying, I'm going to replace your knee because your knee is just awful. And what they do is they tend to bring in 6 or so separate trays full of orthopedic equipment with every kind of joint in the world imaginable on there. And at that time then, the surgeon, who beforehand knew exactly what he was getting into, knew you needed a knee replacement, makes a cut in the knee as straight as he can, and then starts to decide which knee replacement which size is the right one here. So even so they knew what was going on, they're sort of winging it inside, trying to decide which of these is the right knee for you. Well, again, if you could know that before you went into the operating room, as an example, you would then not have to actually figure it out in the operating room, which takes time, which you may or may not be entirely correct. On the spot, you will probably do a very good job selecting the right knee, but if you knew beforehand, that'd be better. Is another example. Someone who has a stroke. Well, the more time a vessel going to the brain is occluded, then the more brain dies. As they say, time is brain in the stroke business. And so you want to get a patient in the cath lab as fast as you can, get a catheter up into the vessels, into their brain as fast as you can, and get rid of that clot somehow, either by aspiration, by some sort of a clot-busting drug, a variety of things you can do, right? Well, not all catheters, there are a lot of different catheters out there. And you may choose your go-to catheter, which almost always works. But if that certain patient has some sort of anatomy which prevents your go-to catheter from being the optimal catheter, and you realize, I really can't get this catheter in place, I need to take this catheter out and put this other catheter in there, which actually would do a better job in this patient's anatomy, you do that. But what happens is, number one, you've wasted a catheter. But number two, you've wasted time, right? Because you tried with the first catheter, you realize this doesn't work. You pull that catheter out, you put a new catheter in, and then you got to the clot, hopefully. You got rid of the clot, but more time has gone by, and the patient will have a less good outcome. So if you could know beforehand, not just that, wow, this patient has a stroke, it's in this segment of the artery, and I need to get it out of there, but you could actually see their anatomy beforehand to where you could pick the right catheter every time, or virtually every time, again, that's a savings. And so we're really going to the point where it's not just sort of understanding the anatomy in general. It's understanding your anatomy, and it's picking out the right implant for you. It's picking out the right catheter for you. It's making your operation go faster and smoother. And once again, the right patient, the right treatment at the right time. Well, if you're picking the right catheter for that patient, then your procedure time will be less. The amount of time your brain is ischemic will be less, and your outcome will almost certainly be better than if you are just simply deciding intraoperatively which catheter you need, and you might be wrong. And in those cases, it's not a physician's fault. They made a good choice. It just wasn't the right for that patient. And if you can avoid those scenarios, then you will have better outcomes for your patients. You just will.
Yeah, and I guess that's sort of ties back nicely to the kind of the answering the why of doing something like this. If
Absolutely.
maybe 10% of the stroke cases, the surgeons are in their best pick, but it's like the analogy you gave me with the start is person's turning up, and I'm just kind of seeing what's there when I get there. And 10% of the time that goes wrong. If you can reduce that to 5% or even 2%, because things will go wrong, that's a massive improvement for patients everywhere. And that's where I suppose nicely I can kind of maybe introduce that idea is that, like you said, we maybe start off with X-ray, and then we get to CT, and then we get to MRI, and then we get to interesting things that imaging companies are doing in terms of cleaning up image, so the kind of sharpness is getting better. But then when you can create that 3D map of that patient, that's when you get closer to being able to solve which catheter or which device or which implant should I be able to use. And that's from my world where I come from this, and as a technologist, it's really, really awesome to see the things that have accelerated over the last 5-10 years in terms of cloud and AI and machine learning, being able to create things like 3D models or to map a catheter onto a patient's vessel, is that when those two things come together, you get something entirely new.
Absolutely. With better and better pre-surgical imaging, the amount of information that you're confident in steadily goes up, and the amount of gray zone which you're unsure of will steadily go down. And the more confidence you have going in, and the less uncertainty you have going into a procedure, the better it will go.
Right. And I think one of the other things that I think certainly from like our side of exploring this in what we've been working on over the last few years, and actually there's that confidence kind of going into a surgery actually reaches all across the board in terms of experience level. So for someone who's a tenured clinician, there's still, without the kind of additional information that we've been kind of chatting about being available, there's still a little bit of uncertainty doing the procedure, even if you've done it 100 times before. But that kind of information really, really helps people who are at the start of their journey in kind of surgery as well, is that like that extra information allows them to better understand unique cases they may not have seen before, things that aren't in textbooks and so on.
There's no question that with a variety of knowledge, and even if you get to the point where you are able to practice a procedure, or not just a procedure, but practice the specific procedure which you're going to be doing on somebody, you can massively accelerate your learning and the efficacy with which you will do an operation. There's no question about it.
And the other factor here, I suppose, as well, and interesting to see if this is kind of playing out in the healthcare system that you look after, Chris, is that we change in population. People are living longer, but because we're living longer, things are breaking a little more. So it's sort of good news, bad news, in that everybody's healthier, living longer, but the need for procedures like we chatted about, things like knee replacements or hip replacements or even cardiovascular type kind of treatments that you might need, heart disease, things like stroke and so on, they're increasing basically.
There's no question that they are, and what that will do is drive up costs going forward. I mean, if there are more and more knee replacements being done, then there's more healthcare dollars being spent, and if there are more heart stent procedures being done, that will drive up healthcare costs. There's no question about it. And so, we have an obligation as an industry to try to do whatever we can to make that care more efficient, make it more cost effective, and so that's done in a variety of ways. It's done, in our setting, in the acute care setting, for example, it's done by trying to decrease the length of stay, decrease the complication rates, and increase the efficiency with which the throughput occurs. On the preventative care side, of course, it's done with things like trying to lower someone's overall cholesterol level to minimize their heart attack in the first place or minimize their chance of a stroke. And so there are a couple parts to that. But yes, as the population ages, overall healthcare costs will go up. And it's incumbent upon all of us to try to do whatever is possible to minimize that cost experience.
I think for me as well, one of the things that's really fascinating about especially in the digital side of things in terms of technology is as well as improving outcomes for patients directly who are undergoing procedures and maybe helping with some of the things that you've talked about answering the why should we do this. So reducing time, reducing costs and so on. It allows, I think with some of the technologies we're starting to see, it's allowing clinicians to bridge the gap in terms of communication between their world of what used to be things like, DICOMs and MRIs and X-rays and ICD-10 codes and language that a patient doesn't understand. And actually, this is your heart. Look at this. It's not just gray on the screen. There's a model here that you can have a look at. You can understand what I'm talking about when I say your arteries are in a bad state. You maybe need to walk a little bit more before we're dealing with an acute situation. So it sort of feels to me like there's other opportunities that you can kind of go towards here as well as somebody who's innovating in healthcare about helping communicate with patients a little bit better. And I think it goes a little bit way towards what you mentioned as well, Chris, in terms of people have all this information on the internet that's available. A nice way of addressing that head on is kind of going, well, yes, that's all true, but this is you.
There's no question. In fact, there is data out there that shows that if you show somebody a 3D model of their anatomy, explain to them all of what their anatomy is, explain to them, show them all the bad parts, and say, here you go, take this home with you and talk to your family about it. They will understand far more and retain far more of that discussion than if you don't. Obviously, if you go into your doctor's office and you say, my knee is really killing me, and the doctor says, well, the x-ray shows you got a lot of arthritis. See, it's here, it's here, it's here. We need to replace your knee. And, you talk about it for a while, and then you go home, right? And then you go home, and your spouse says, so what did the doctor say? Well, I got a bad knee, and need to have a knee replacement. All right, well, what else? It's bad. It's really bad. I need surgery. It's bad, right? But if you do it differently and you say, okay, Mr. Jones, this is your knee, and you show this model. You see this rough stuff right here. This is arthritis. See, when this moves like this, it's not gliding. It's roughing over this stuff. And this, what we're gonna do an operation, and we're gonna make a cut right here, and we're gonna make a cut right here, and this part is going away. We're gonna put a replacement in here, and a replacement in here, and it's gonna be smooth, and it'll rotate just like this. And this is what it's going to be. It's going to go right like that, and then you'll be able to bend better, and by getting rid of all this rough stuff. And by the way, you can have this model and take it home with you. And then so that patient goes home, and their spouse says, well, what did the doctor say? Well, let me show you something. This is my knee, right? And you have that visual understanding so much more than you would have had. And the data does show that patients, their pre-surgical understanding, their informed consent is better. And their overall happiness with the procedure, with their doctor is better. Their belief that the communication with their doctor is better. A lot of times you need to trust your doctor, and if you don't understand what they're talking about, that doesn't really help, right? So if you can help the patient understand their condition, and if you can help them remember what you talked about, and show them a model and give them a model and have them take the model home with them, because what's the doctor going to do with the model after that, right? They already knew what they're doing. So you give the model to the patient, they take it home. It really is a tremendous benefit to your pre-surgical relationship building. It's a benefit to the patient and understanding what's going on. And there are significant benefits to that.
How can we as technology companies and kind of, I'm going to say you as the kind of hospital systems in this instance and so on, how do we keep on accelerating that or finding those opportunities to join together interesting technology and problems that are real, that are here today, and figure out how can we apply innovation or technology in an interesting way to kind of move things forward from either from a cost point of view or patient outcome point of view or.
Well, I think you need to talk to a lot of people and just keep talking to people, asking them what sort of problem they have. If you have been doing something one certain way and that's the way you do it, you may think it's just fine. and you may not recognize some of the problems that you have. But if you talk to 7 different people, maybe one of them will say, you know what, there's an issue that comes up with X, right? And you may not even realize a lot of doctors don't realize what problems there are because you know what, they've been doing it this way for the last 10 years, things are going fine, and they may not realize the burdens that they're bearing. If you think of Steve Jobs with Apple, he didn't do a whole lot of focus groups. He sort of told people what they needed, right? I mean, it wasn't like someone said, I need a touch screen. He just sort of said, here you go. I've got this iPhone thing for you. And, it was such a big difference. No one said, I need a better smartphone because there wasn't such a thing. Basically invented it, told everyone, this is what you need. And everyone said, wow, this is really awesome, right? Well, it wasn't like there was a gigantic groundswell for a smartphone. So in a similar fashion, it may not be obvious to some people in the medical community what would be a great improvement in their situation. And so I think from your standpoint, it's incumbent upon really talking to a lot of people, or from a company standpoint, talk to a lot of people, because here and there you're going to find some real nuggets of interesting things which are a problem, which could be benefited. And so then once you find those, you can do a little bit of a deeper dive to see, hey, is this really a systemic problem? And if it is, then you have a real opportunity to make a breakthrough and benefit a wide swath of the medical community.
Sure. And in doing that, again, come back to the phrase you used, which I love, which is, answer the why. If you can start to identify some of those kind of whys through the conversation, then you're probably in a much better place from a developing technology point of view to have something that's going to successfully impact healthcare, rather than kind of coming up with something on your own and then turn it up to a bunch of people and go, does this help? It's a talk to your users first, essentially, is the key thing there, or the people who have the problems.
But going back to the orthopedic situation with the knee, for example, if you've been doing knee replacements for 10 years, and the way it is they bring in all these different trays, and right there on the table, you figure out which one the best is, and you go, okay, and that's just the way it is. And you say, what problems do you have that we can sort of fix? And they say, things are pretty good, right? They may not even recognize that, there's another option which is completely outside the box, which is, before you even go in the OR, you decide what knee you need, and what size is the right size. And then when you go in the OR, you just sort of peel pack open the one, drop it in, say that's the one, and put it right in. You get rid of that entire decision-making process intraoperatively. That option may not even occur to a lot of the physicians out there, because it's not what their experience has been. The way we do this is we have all of these different knees, we measure it intraoperatively, we decide intraoperatively, we pick the right one, we fit it, we measure it, and we put it in, right? So, 9 out of 10 may not say anything, but one guy may say, it'd be kind of nice if we didn't have all these things right here and we got to only use one. Or an orthopedic company may say, man, it sure does cost us a lot of money to have to ship all these gigantic boxes of these massive trays of equipment, which are like 100 pounds each. They're heavy, they're big, we're shipping them all over the country. It'd be great not to have to do that anymore. Oh, well, how can we make that happen, right? So there are multiple different sides. And if you're talking to all of the people involved in various processes, they may give you some sort of they may just accidentally let slip one of the problems they have, which they don't even realize is a problem and don't realize there's a good solution. And you may be able to say, hey, I can fix that for you.
Yeah. And I think that's just again, in this space, I think that's the really nice thing, is that everybody who would be part of that conversation wants to make things better. There's incentives across the board to try and make a difference and try to improve how we're doing things in terms of care. And I think, your ear talking to us today, Chris, I think certainly I have, over the years of working in around healthcare from a technology point of view, found I've never found anyone who doesn't want to talk about how to make things better. So for anyone who's starting off or has an idea for an innovation, I think you probably find there's lots of doors that are open to you to just have initial conversations around problems and challenges.
Absolutely.
Fixable. Awesome. So any kind of final thoughts from you, Chris, in terms of where things are going in future? What are some of the kind of key things that kind of are on your mind in terms of innovation in around patient-specific planning, or where we're heading in the future?
I think that the future is going to be much more individualized and patient-specific, because we're not all the same. In the implant business, the exact same thing will be happening. We can bring everyone the exact same number of knees into the room, or the exact same whatevers. But if we can make the right one for you and immediately give you the right one, then it's just an improvement. And we're going to see this over and over again. We talked about catheters, but it's also in implants all over the body. It's in deciding if what you're doing is the right thing. It's in being able to measure lesions on an imaging study better and better. All of these things are going to keep happening. And as we do so, we'll be able to tell much more rapidly if the drug we're giving is working, if the cancer is shrinking, if the implant is the right size, and if you give someone the right care at the right time, you will have better outcomes, as we talked about before. And if you can minimize the amount of time you're wasting or spending or using intraoperatively or inside the procedure room, if you can decrease the amount of time which you are having someone on a drug and waiting to see if that drug is working, all of these sorts of things are going to benefit that individual patient. And patients need to be thought of as an individual, not as just a mass, another person with a thyroid lesion, another person with arthritis, but they are an individual. And if that individual gets the right care for them, they will have better outcomes than if they get the care that is better for most people in general. And you need to be treated as an individual because we all react differently. We respond differently to different things. And I think that patient-specific medical care is the next major breakthrough. You see it in cancer, and you're going to see it in other diseases as well. You will be seeing it in implants, and you'll be seeing it in procedures. It's just the way of the future. Absolutely.
Perfect. Chris, really appreciate you taking time today to chat to us. We hope everybody's enjoyed our conversation, and hopefully you'll tune in to the next episode. Chris, have a great day. Thank you for talking. Catch you again soon.